Yes, we are perfect. Perfect. Yes, we're ready. I'll call on the microphone. Yeah. Yeah.
Good evening, everybody, and welcome to the third part of our CPD research series. Today we are blessed with a very strong panel of speakers who will be presenting to you in a short while. Before we start, I'd like to draw your attention to other events coming up this month, all of which are available to register on our website. So I'm just going to share the CPD website with you now. So you should be able to see the website. There have been some issues with participants accessing the link, the WebEx link for the sessions. So what we've done going forward, we will be presenting, or we will be putting the link on the actual registration page. So when you come to register, you're all familiar with this screen. So it's probably just a bit bigger on your screens. And then at the bottom, you've got the WebEx link here. So this will be the WebEx link that you can use to access the event. However, if you do want to claim CPD points, it is important that you still register. So you'll have to select a healthcare professional and then register in the normal way. But the link will be available on the website. And as you saw, coming up this month, we have, next week we have two events. The first of which is on Monday evening. It's the psychosocial models, social cultural determinants and coping strategies during COVID-19. So it's World Mental Health Day on the 10th of October, so a few days ago. So to raise awareness around World Mental Health, we're holding two events, the first of which is next Monday, and the second is on the 26th of October. 26th of October, you can see the psychological flexibility and its role in the times of COVID-19 adversity. So these are the events coming up, and I'd encourage you to register, and we look forward to welcoming you at these events. At this point as well, I would like to welcome our viewers on YouTube. So this event is also being streamed live on YouTube, and we'll be monitoring the chat function both here on WebEx and on YouTube as well. So we do encourage and we do like interaction in these CPD sessions, so we very much encourage your questions. You can ask questions at any point, and then I will be reading your questions to the speakers. They're well equipped to be taking your questions this evening. So without further ado, I will hand over to our first speaker today, Dr. Hazm Elua from the College of Pharmacy. Okay, Dr. Hazm, you are now the presenter. You should be able to.
All right, thank you so much, Dr. Zakaria. Hello, everyone. I'm going to start sharing my screen now. Hopefully, everybody can see my screen. Perfect. All right. Hello, everyone, and good evening. Today or tonight, we're basically going to be talking about quantitative studies. So these are our learning objectives, as you can see. We'll start with the cohort studies, how to differentiate them against case control, what are the different types of cohort studies, prospective, retrospective, ambidirectional, and then we'll move towards the end to also the quantitative survey with Dr. Kazem. We'll talk also along the way about the different steps that we have to take in order to design a cohort study, including exposure, sampling, inclusion-exclusion criteria, follow-up. And then with Dr. Dan, we'll be talking about the evaluation of the quality of cohort studies and using systematic critical appraisal tools. And then also one of the things that we will be doing is to report how to report and interpret results of cohort and quantitative survey studies for practice and future research. So with the first part, talking about the design, which will be the first half an hour with myself. I would typically start with a slide like this to understand and explain why do we need to have a good study design. If you can imagine yourself in the place of this anchor man sitting to talk about random medical news, and you want to report some studies, and unfortunately you don't have a study that is well designed. You will be basically as if you're just playing a roulette and you're just picking a kind of food or any sort of an exposure like stress, coffee, you can name it, and then you can start to play the roulette again and say this can cause something like hypertension, and then you play the roulette again, and then you say it can happen in men between 25 and 40 years old. So all of that is just, you know, playing by chance with no whatsoever any kind of validity or credibility. So this is exactly what happened if we don't have a well-designed study. And you also, if you can imagine yourself as audience, as well as myself, I mean, we will be distracted. We will be kind of like not knowing what to believe in and what not to believe in. And we do see that nowadays a lot, especially with all the social media, all the news that sometimes don't have the credibility, or maybe citations and papers that are not very well designed. Some people would tell you, okay, well, eat more eggs, they're good for you. Some would say, no, they're not good for you. This study showed that, this study showed this, and you will not be knowing what exactly to believe in. So with all of that, it's very important to have your study well designed. So going to the quantitative studies, we have two main types of studies, what we call descriptive, like case reports, case series, surveys, and then what we have as analytical or quantitative analytical studies. And those could be either observational or experimental. And we're going to talk about them more in details. But if we think about the analytical studies in general, it's all about trying to find out whether a certain exposure to a factor, whether this is a risk factor, like smoking, for example, or something preventative, like a treatment, would increase or decrease the risk of an outcome, like a disease, death, or something intermediary, like lipid levels, let's say. So it's all about finding this association. Is there an association between that exposure and this outcome or this disease or not? So this is all what you typically do in an analytical study. And for that, you could either do an observational study or an experimental study. So from the name observational, again, you're not doing anything except observing without any interference from your side as an investigator. Like already in your clinics, in your clinical setting, those patients have been taking these medications. You're not giving them those medications to perform your study. What you're doing is just observing those that are taking medication A and medication B, and you want to see what's going to happen. In experimental study, on the other hand, it's basically you're controlling everything, and that's why we call it experimental, because you're experimenting over here. You control the exposure, the environment itself, the hypothesis that you want to test, and it can be in a randomized format, blinded, double-blinded. And as we all know, the randomized control trial is the gold standard when we talk about experimental, which will be, again, the main theme of the next week presentation. So going back to observational study, we have four main types: cohort studies. We do have the case control studies, we have the cross-sectional, and what we call the nested case control. So how do we differentiate between them? If we look over here in the cohort study, typically you have to think about what you're starting with. So in a cohort study, you start with your exposure. So you start with exposed versus those that are unexposed, and then you track down over the time a disease or an event development. On the other hand, case control, you are doing the opposite. You start with your disease or with your outcome, and we call those cases, versus those that don't have the disease, and that's why we call them control. So case control is coming the name, and then move backward in time in order to examine, is there a relationship between that exposure and this disease status or not? Nested case control, on the other hand, is sort of a mix between case control and cohort, and from its name, it's basically a case control, but it's nested within a cohort study. Like, let's say you have a big cohort study that is going on, and you already found out about one of the outcomes, but you have another outcome that you did not relate really to exposure. So you can take later on that outcome and try to relate it to whatever causative factors or exposures that have caused it within your big cohort study that you have. And that's why we say it's nested within the cohort study. And then lastly, the cross-sectional. Basically, from the name, again, it's a cross-section across the time. So it's a snapshot of the population in which the exposure and the outcome are measured both at the same time. And a good example for that are like the prevalence studies. So for example, I want to know what is the prevalence of diabetes in Qatar right now. So I'm not doing any follow-up over the time. I just want to check it now. Another good example is basically quantitative surveys. And we will discover more about that with Dr. Kazem. So again, to wrap up, this is showing the different types of the observational studies. Cohort, your present, you're looking at the exposure, and then the future is your disease or your outcome. Case control, your present is basically your disease, and then you look backward in time to see how it's linked to exposures that happened before that. And then the cross section, both the disease and the exposures are happening now at the same time point. So let's see how did we do over the past few slides with this question. Over here, we're gonna have a poll. So I will just present the question. You would like to study if there is an association between respiratory tract infection and vaping. Which one of the following is the best design for your study?
Okay, so we've administered the poll. You should see that on your screen. There's about 15 seconds left to register your answer. About half of the participants have so far responded. Okay, so I'll show you the results.
All right, so we see about 7 choosing cohort study and 4 taking case control, maybe a little bit less for cross-sectional and randomized control studies. We still have more people who did not participate. Hopefully they will participate in the future questions. Well, if we think about it, definitely this cannot be done through randomized control studies, because if you think about it, it will be unethical basically to kind of tell a group of patients or a group of people to try vaping and another group not to try vaping. So that will be unethical. So definitely I will not choose that as a design. Also for the cross-sectional, I will not pick that because, again, we want to look at an event that is going to happen over time. So cross-sectional is not an option for me. Cohort study and case control, both of them could be actually used. So I would say both of them are correct. Again, it depends on how you're going to do it. So for case control, you will start with looking at a group that have respiratory tract infection and another group that don't, and then look into the past to see who were vaping among those. Cohort study on the other side, you will start with the vaping. Maybe you look backward, which is we're going to explore retrospective cohort study and see who was vaping and who are not, and who is going to develop respiratory tract infection. So again, I would say 1 and 2, both of them would make sense as an answer. So moving to the next slide. Over here, we're going to talk more about the cohort study, what it means basically. So cohort study, as we said, it's a sample based on the exposure status, treatment, or any other factor, and then tracking down over the time the disease or the event and how it's going to develop. It's coming from the Latin word cohors, which basically coming from the Roman, during the Roman era, where they used to have big armies. Each army was composed of 10 cohorts or 10 units. So basically, cohort is kind of like a unit. So what are the types of cohort studies? We do have 3 main types, what we call prospective cohort study. And from the name, prospective mean looking into more to the future. So over here, you are grouping your subject right now into those that are having the exposure versus those that are not exposed. And then you look to the incidence of the outcome over the time in the future. Like this example that we have a group that are obese and group that are lean, and you want to see the incidence of, let's say, diabetes, cancer, or cardiovascular disease. A retrospective study, on the other hand, is also another type of cohort study, but the main idea here is that you're looking at your exposure as well as your outcome in the past. So the groups are subjects to their exposure status that happened in the past, and then you look over the time also that happened in the past, how did they develop a certain outcome? Like an example that we have over here, we have employees that are working in tire manufacture, and group of them are basically the tire makers exposed to those chemicals and so forth. And we have another group that are working the same company, but not necessarily working with the tires directly. And we want to see how did they develop, maybe cancer, or if they died. So this could be our outcome of interest, and we want to see how if really the byproducts from that tire manufacturing did cause that or not. So both of them are happening in the past, but making sure that our exposure was before the incidence of our outcome. And then we have what we call ambidirectional cohort study. And in that, it's kind of a mix of both retrospective and prospective, if you will. So you have an outcome that maybe happens in short time and have another outcome that can happen, but in a longer time point. So it's the same exposure and the group that is control or unexposed. And you have a short-term outcome that you could look at in the past, but you have another outcome that you need to look more into the future in order to find out if it's gonna happen or not. But again, it's the same exposure and unexposure group, short-term outcome, long-term outcome, one in the past and another one for the future. So this is the ambidirectional. So again, going to question 2, and we'll have another poll now. So the question states, apixaban is a newly introduced anticoagulant in HMC formulary. You would like to design a cohort study to determine the effect of apixaban compared to dabigatran on the incidence of bleeding. Which of the following is the best design for your study?
You should be able to see the answer on the screen.
Great. So as we can see, we have also, again, maybe majority answering prospective cohort study, which is the correct answer. We have also a little bit answering retrospective cohort, and I'm glad that we don't have that much going with the ambidirectional or nested case control. So definitely over here, I would consider nested case control not appropriate at all because this is a sort of a case control. And we said that this just was introduced. So looking into the past is not going to really help us. And it's the same reason why retrospective cohort study is not going to be helpful. Because as I said, this is a drug that was just introduced to the formulary. So in order to look at it, you basically have to start with your exposure, which is this drug against the dabigatran, and start to look into the future. If you look into the past, already apixaban was not there. So that's why retrospective will not be helpful at all. And ambidirectional also is not the case that we want to use over here because our exposure was not in the past. So I would say, yes, prospective cohort study definitely is the best design that we should use. All right, so now moving to the elements that we should consider when designing a cohort study. Definitely, we have to think about the selection of our design, and we explained the different designs. Selection of subjects, the exposures, as well as the control or unexposed, and then the outcomes, the follow-up duration, and we'll go a little bit into the statistical analysis if we have time, as well as the risk of bias, internal and external validity, and more in depth about that with Dr. Dan. So in order to make this process easy, I decided that we pick some sort of a research question you would like to compare between 2 different types of diet, Mediterranean and DASH diet, and you want to find out about how they can impact diabetic patients in Qatar. So our exposures over here, as we can see, we have the Mediterranean diet and we have the DASH diet. You can consider one of them as the exposure, the other one as the unexposure, if you will, and then how they're going to affect diabetes-related outcomes. So first of all, we did not really pick an outcome over here. All what we said is that it's going to be diabetes-related outcome. But which outcome exactly do I want to pick? It's important for you when you are designing your study is to pick appropriate outcome and an outcome that you could measure easily and with a great feasibility. So in cohort studies in general, you could have more than one outcome. So it's not necessarily just one, you could have more than one. So definitely this is something that we should consider, whether we want one or more. And then which one, if you're going to pick more than one, which one among those is going to be your primary outcome? So it's important to identify your primary outcome because your sample size calculation, or if you want to call it the power analysis, is going to be dependent on the primary outcome that you will pick, because based on the expected difference that you are hoping to see between your exposure and unexposure in terms of the outcome, you will pick your sample through the calculation of the sample size. And this is definitely done through more sophisticated statistical analysis, but at least for you, when you're designing, you need to determine which one is going to be your primary outcome for that purpose. Also, it's important for you to identify whether in a study like the one that we're going to perform, you want something that we call a surrogate marker or a hard marker or endpoint. Well, when we say surrogate, we mean it's something that correlated to an hard endpoint. So for example, fasting blood glucose is considered to be a surrogate marker. It's a surrogate marker for what? For the complications that we see with diabetes. So the higher the fasting blood glucose, typically the more complications we would see. What kind of complications or hard endpoint? It will be things like incidence of microvascular or macrovascular complications. So this, we call it a hard endpoint or hard clinical point. So again, for you, is it maybe if you want to do something that is short term or maybe piloting, maybe it would be good just to look at a surrogate marker. If you want to go more in depth with something more higher in strength and evidence in terms of clinical evidence, maybe it would be great to also pick a hard endpoint. So again, it depends on what is your plan, what is your budget, what is the timeline that you have to perform your study in order to pick the outcomes that are appropriate. So for us, maybe let's say we want to just go with something that is surrogate. So we decided to pick hemoglobin A1C as our primary outcome. And we also want to measure the BMI and fasting blood glucose level as another two endpoints that are important for us to look at and see how really the Mediterranean diet versus the DASH diet will affect those. So now moving to the design. Okay, we said that we have prospective, retrospective, and ambidirectional. In here, would you prefer to use prospective or retrospective? Again, before you decide, you have to consider a lot of different factors. First of all, what kind of source information do you have or you're going to rely on when you are performing your study? What is the quality of that documentation? So if it is going to be a retrospective study or a retrospective cohort study, that means that it's all going to be happening in the past. So that means that you will have to rely on either the interview of the patient, and you have to rely that they will be really remembering everything that they have done in the past, which is sometimes hard, or you have to rely on information from Cerner or from medical charts. And you want to make sure that is also a very good documentation of that. So if this is the case and you're trusting one of these sources, maybe you can pick a retrospective design. But if you're not 100% sure and you're afraid of this and how it can affect your study validity, as we're going to explore more with Dr. Dan, then maybe it's much better for you to go with prospective. So prospective is considered to be much, stronger in terms of its validity because you will be, have higher ability and better ability to document and make sure you have appropriate documentation and data gathering when it comes to your exposures, to your outcome, and your follow-up. Also, the time availability that you have to conduct your project. I mean, as we said, the time line is very important. I mean, do you have only a few months and you just want to finish your project in a short period of time? If this is the case, I don't think you'll be able to go with the prospective cohort study. The best design for you will be retrospective because you just can collect all the data that you need, even if it happened over 1 year or 2 years. You can just gather all of that within 1 month. But if it's going to be prospective, that means that you have to wait until your outcome happens, which could be a year or year and a half, and we'll explore that further in one of the next slides. And then finally, the resources that you have. So do you have budget, for example, that you could hire a research assistant or coordinator that would be able to do the follow-up visits and do that prospective, work for you? If this is the case, again, prospective would be great. But if you don't, and you're just going to be doing everything by yourself and you don't have any other manpower, maybe prospective study would be difficult because you need really time and you need resources in order to dedicate it for meeting with those recruited patients, gather all the information appropriately, doing the consent. Prospective study of that sort will probably definitely need a consent as well. So this is one of the other things that you have to always think about. Choose something that is feasible according to the resources that you have. So let's say that we do have a great budget, we're rich, and we were just funded with a grant, and we decided to go with a prospective cohort study. So as you can see over here, at the present, we're starting to look at our exposures, Mediterranean diet versus DASH diet, and then in the future, we will be assessing our outcome or endpoints, the hemoglobin A1C, the BMI, and fasting blood glucose. Now we move to the subjects, the exposures and the non-exposures, and how we really pick those, and what is going to be our eligibility, inclusion, exclusion criteria. What do we need to think of when we determine that? Well, we have to always think about what we call the sampling frame. And the sampling frame, think about it as the boundaries. And within these boundaries, you have your inclusion criteria, and outside these boundaries, you have your exclusion criteria. So your sampling frame basically should not be too wide to have so many confounders, but at the same time, it should not be too strict to have hard time to recruit subjects. What do we mean by that? Basically, when we say the word confounder, we mean that this is another factor other than our exposure that have led to our outcome. So let's say in our research question, we have some patients that are taking weight loss medications. Definitely we would expect that to affect our outcomes, right? So we want to make sure that maybe we don't include any patients that are not taking weight loss medications. But at the same time, we know also that something like metformin, if those we're talking about diabetic patients, many of them will be taking metformin. If I put metformin as an exclusion criteria, honestly, I would be eliminating 95% of my patient population. So I'm going to make it very strict and very hard to recruit any subjects. I would rarely find anybody who would meet my inclusion-exclusion criteria. So I'm not saying that having metformin is a good thing, but at the same time I have to have it in there. So instead of removing metformin, I just want to make sure that I have the metformin patients balanced between both of my groups. I have similar percentage of metformin in my group A and in my group B. So that way I did not remove the confounder, but I made some sort of a balance between both my groups. And Dr. Dan, again, will focus more on that point. So another important criteria is you want to make sure that the data or like the patients that you're picking, are very general, sample that is representative of the population. So are you going to pick patients that are followed at HMC, PHCC, and which kind of clinics? Maybe you want to include all of them. So that's another factor that you should kind of think of as well. Because we know also that maybe according to the geographical area, you will have different socioeconomic levels. So you want to make sure that we pick patients from different socioeconomic levels. So that will ensure, the generalizability of my study population. Newly diagnosed with diabetes versus any diabetic patients, there's another important factor maybe that you have to think of. How about other comorbidities, having a high BMI, like morbidly obese versus just kind of, overweight? Which one are you going to pick, or are you going to make it open? So those sort of things are important to put into consideration. And then making sure also that you have those patients that are agreeing to adhere to the assigned diet, because we know that these kind of diets will require patients to be, adhering to them in order to have appropriate outcome that assess really the exposure. So you want to make sure that they would be adherent to that, and then also that they would sign informed consent. So we know for this study, because we will be not really doing any intervention per se, but we will be kind of meeting with those patients and gathering data from them, then we will need an informed consent. So that is another important factor to consider. And then one of the last points that we want to discuss as well is the selection of the follow-up duration. If you remember, we mentioned that the follow-up duration could be 1 year, 1.5 years based on my outcome. So before I decide on my follow-up duration, I have to consider the following. When would I expect this endpoint or this outcome to occur or to change? So again, for something like hemoglobin A1C, and you as clinicians, definitely you will have great idea about that it could change maybe in 6 months or maximum a year. you would see significant change and a clinical change that is really clinically significant. On the other hand, if you want to pick something as occurrence of microvascular complication or macrovascular complication, we know those take years and years for them to happen. So that means that you will need your follow-up duration to be 2 years, 3 years, who knows? So these are the things that you have to consider based on your outcome and when you would expect it to occur or to change. Frequency and type of follow-up visits. So let's say, again, if we're sticking with the hemoglobin A1C, how often do I want to measure my hemoglobin A1C? Maybe I want to do it every 3 months. So it's not just one time point, because maybe I want to see how it's going to, the effect of the time as well. Is it going to start to change after 3 months or after 6 or only after 12 months? So it's important to collect that over time as well and have multiple follow-up visits. Again, to do multiple follow-up visits, you need to have resources, as we said. So you want to make sure you have manpower, research assistant to be able to collect all these data from the patients at these multiple time points. And then if you're going to have multiple time points, make sure that your patients will be able to either come to your clinic, or if you want to do that over the phone, let's say, because if you want to bring them to the clinic or to the hospital, maybe it will be too much for them and then they will decline to participate in your study. So you have to be smart in a way, but at the same time, not really to compromise the quality of the data that you want to collect. So this is basically kind of like the full design of our study. We have the Mediterranean against the DASH diet, and it's going to be a prospective, and the follow-up duration, we decided that would be 52 weeks or 1 year. And these will be our outcomes and endpoints. So hemoglobin A1C as the primary, BMI and fasting blood glucose as our secondary outcomes. And I honestly like to have these kind of graphical presentation, even when you're submitting a grant. I actually review grant myself from other agencies, and I find it really helpful for reviewers and for anybody who's reading the study to understand your design and make it easy. So it can really help you to make you more successful to obtain funding. So now we move to the data collection, and the data collection is something really general that is important to consider in any kind of study. And before you start your study, you have to think about, okay, what kind of data collection tool you will be using? Is it something electronic or paper-based, like an Excel sheet that you'll be printing out, or something on PowerPoint? Or it could be something online. And there are now many online platforms that you could use for data collection, and where you can put, coded data for your patients without putting any identifier for the patient. And you typically have to do that definitely for your baseline characteristics, where it's very comprehensive. You collect so many data parameters that are important to the subject of your study. And at the same time, you will also have follow-up visits, and those would be, as we said, maybe 3 months, 6 months, 9 months, and 12 months. And you have to kind of decide, what do you want to have in these follow-up visits? So other than the exposure and the outcomes, which you always have to have in those, maybe you want to collect also other prognostic factors that could impact your outcomes. So for example, physical activities that the patients are doing, any change in medications, weight loss medications, as we said. And so these kind of possible confounders are very important to be collected as well. So now moving to the last 3 questions before I end my part. So question 3, and we'll start the poll now. All of the following is important when you pick your sample frame, except.
Okay, about 5 seconds remaining. Please let me know if we're not giving you enough time to answer the questions. We can extend the time for you.
All right,
Okay.
so again, I do see over here equal proportion of choice number 2 and choice number 4. So again, if we think about that, if we go one by one, basically the sampling frame should be wide enough to ensure generalizability. And we said, yes, this is very true and important. Eligibility criteria should limit the inclusion of major confounders in your sample. And we said also, yes, we definitely try to do that. So I would say this is also, important. So it's not the correct answer. Selection of subjects should be performed in a systematic fashion. Again, selection should be done in a way where it's homogeneous. So do that in systematic fashion. And the sampling, it's another, huge topic that we don't have time to cover, but it's important to do that as well. So answer number 4 is saying samples should always include different genders and all age groups. And this, in fact, is not very true in all types of study, because some studies are specific to a certain population. We have studies that may be testing oral contraceptive pills. So those would be just for females, or something that is related just to medication that is taken by elderly for Alzheimer's, let's say. So I would expect to see only elderly patients. So I would say all of this is important, really, except choice number 4. So question 4, and again, we can start the poll now. Which of the following is an important fact regarding a study primary outcome? Right, and again, over here, I do see the higher proportion going for answer number 1, which is actually correct. So definitely an important fact is that different primary outcomes may require different follow-up durations and different sample size to be achieved, as we said. All the other answers, if you read them, you will find that really they are not giving a true information. Primary outcome is not necessarily the easiest to achieve. And we do have sometimes primary outcomes that are composite. It doesn't have to be a single. As you know, in many of the cardiovascular disease studies, we do have what we call the MACE, or the major adverse cardiovascular events, and it's a composite outcome of different things happening, like mortality, as well as incidence of stroke and myocardial infarction. So definitely it could be composite as well. And then last question for me is, in a retrospective cohort study, all the following strengthen your study design except. Okay, great. And over here as well, I see that we have also majority answering for number 3, going for number 3, which is the correct answer. Because if we look at it, having a common exposure and a rare outcome, it doesn't really strengthen your retrospective cohort study. In fact, it makes it way more difficult, because typically to achieve this rare outcome, that means that you have to have a very, very big sample size. And that may be very hard to attain, especially when you look at it in a retrospective manner. And when you have a situation like this, it's much better to go with a case control rather than just actually going for any type of cohort studies. If you look at all the others, they are actually very true. So the exposure group, definitely we want to make sure that it happens prior to the outcome of interest, and which we call the temporal order. And you want to make sure you have reliable source of information for your variables. And you want to make sure also that you adjust for confounders to maintain the internal validity. So with that, I'm going to end it from my side and switch to Dr. Dan. I would like to thank you all for your attention. I'll be here till the end to answer any questions you may have. Thank you. Moving to you, Dr. Dan.
Great, I've got it. Thank you much, Dr. Haslam. And good evening, everyone, and welcome back if you have joined us before. If this is your first time joining us, then welcome. For the next about 25 minutes or so, we're going to talk about the critical appraisal of cohort studies. So taking it from the perspective of both being able to create the new knowledge, so actually performing studies, but also from the perspective actually evaluating studies and looking at some of the cohort studies that have already been published. So to give you a quick idea of sort of what we'll be talking about in terms of critical appraisal, the goal that we're really aiming for is for us to be able to determine the validity and the reliability of the evidence that is being presented to you. Question is essentially, what are the results? Can we trust those results? And what are we essentially going to do with those for our patients? So when we're talking about different sorts of bias within cohort studies, and for any type of bias for that matter, we can come to essentially four major conclusions. The first is a critical risk of bias. This is a component of a study where it affects the validity, the truthfulness of what the study is showing so much that the study essentially almost needs to be thrown out, and that you can't rely on any of that because it essentially is not truthful. There are serious risks of bias which impact the truthfulness of the study. And then we get to a bit more of the gray zone where it's a moderate risk. It might not have been done perfectly, but there are some potential things that we might be concerned about as we're trying to interpret the results of this study. And then finally, and what we are aiming for, is a low risk of bias when we are creating our own knowledge and doing these cohort studies. And when we're evaluating studies, we want to make sure and to ensure that the studies that we're looking at contain, again, the highest validity that we can, the truth of the matter. So when we're speaking about essentially the ultimate question that we're looking for critical appraisal is, specifically within the cohort studies, is aside from the exposure of interest, did the exposed and non-exposed groups start and finish with a similar risk for the outcome, so that we can indeed come to a conclusion of cause and effect as much as we can in the setting of cohort studies, knowing all the limitations that come with that. So when we're speaking about internal validity, here we're talking about the truth. This is essentially from a positivist paradigm, which is essentially is one objective truth that is out there in the universe, and we are trying to see, can we measure and observe that truth? This is not a constructivist paradigm where we are looking at different perspectives and that the truth varies from person to person. That's not what we're looking for in terms of the cohort studies. What we're looking for is to assess the validity of the study. So this is how close we are to the truth and how reliable a study is. Can we actually repeatedly measure and get the same results again and again? In contrast to that, we have another part of validity that is called external validity. And this is known as generalizability and applicability. So your external validity is to say that the sample that you are looking at within your cohort study is indeed representative of the whole population of interest that you're looking at. And the applicability is, can I actually apply this to my patient who is in front of me? And what factors are there that limit me perhaps from doing that as accurately as we would want to? So as the example that was brought up before, so to orient you to this slide, so we have time that's here in our on our x-axis, we have the present. This is our current time frame. And since it's a prospective observational study, the future is going ahead. Us as the investigator here, we have taken a look at the population. We have taken a sample of that. And now we're ready to decide how your participants are going to be in the exposed group or the unexposed group. The first thing that we do is the healthy screen to make sure that, well, if you're looking for a specific hard outcome, such as MACE, or your major adverse cardiovascular events, and if you're looking at it for the first time that a patient experienced it, well, you want to screen those patients and say, if you have any of this already, I don't want you in the study. I want to look at it from a primary prevention point of view. If you're looking at it from a secondary prevention point of view, then that might not matter as much. So it really does depend on the research question that you are being asked. So within our cohort studies, this is where the clinician has the choice to divide the patients into the exposure arm or the non-exposure arm. So in this case, we're going to call the Mediterranean diet the exposure arm. And our non-exposure arm, or second group, we can call it as well, an active comparison group, is going to be the DASH diet. And as discussed before, we're going to measure the specific outcomes of hemoglobin A1C, BMI, and fasting plasma glucose. So while we are looking at this from a prospective point of view, we want to make sure that we have specific points in time in which we are going to collect the data from the patient, follow them up as needed, and be able to come to an accurate conclusion of if the patient is meeting the outcome, or rather, we have the data to draw some conclusions on. So there are some major things that we do need to consider as threats to validity, the threats to the truth of these studies. So these include confounding, as was talked about before, and essentially the question that is being asked here is, do the exposed or non-exposed groups have the same likelihood of and severity of prognostic factors known to be associated with the outcome? So here, if we are looking to review a cohort study, then we would want to do a bit of a search to find out what predictors are there or what risk factors are there for the outcome of interest, because we essentially just want to make sure that both groups were even so that the effect is truly due to the intervention and not due to other factors that perhaps were counted or perhaps not counted for. So the solution to confounding is trying to make the groups as even as possible. And we can do this by the inclusion and exclusion criteria within a study. So as you're within a certain bounds, you either get included or you get excluded from the study. This again begins to limit the generalizability if you have too strict of an inclusion and exclusion criteria. The other way that can be done to adjust for some of this confounding or manage some of this confounding is what's called matching. So here we identify key characteristics known to have a confounding effect on the association of the studies, and then match the participants to minimize the differences between groups. So for example, if we wanted to make sure that we had both age and sex accounted for are equal between the two groups, we would want to make sure that from our entire population that we're looking at, that the sample includes 1 and 1 for each of those different confounders. So what we see here is there still perhaps remains some threats to the validity of the study. What we're thinking about here is we are only addressing known predictors. What about things that either weren't measured, or perhaps there are things that we don't even know yet, gene variants perhaps that are as part of this? And so if we don't know what all these prognostic factors are, or they're not measured, This is where the benefit of a randomized controlled trial comes from, because it balances both known and unknown prognostic factors with the assumption that you have a large enough sample size. So if you get to the end of the study and there's still residual confounders that are there, what we can do is provide some statistical adjustments for these residual confounders. Now, I'm not going to go into detail of how to perform all of these, but I want you to be able to pick up these key words when you are reviewing a cohort study to say, oh yes, that's something that was done well. And that perhaps lowers the risk of bias, or rather lowers the risk of confounding within this. So examples of these are stratification, multivariable regression, and sensitivity analyses. Now within stratification, there is a fancy form of stratification that's called propensity scoring, and I'll leave that for you to read a little bit more about, but essentially what this is trying to do is trying to balance the characteristics, and while trying to balance these characteristics in a mathematical formula. Trying to balance the propensity or the prognostic, the prediction of being able to achieve the specific outcome of interest, or perhaps avoid the specific outcome of interest. Multivariable regression is accounting for multiple covariables that would affect the outcome and perhaps bias the association. Things like this would be, well, age, sure. We know that as we increase in age, the glucose levels perhaps go up, and these could be to a whole host of reasons, but age is something that is simply not modifiable. That is just a part of the study, and so we can throw that into an equation, and we can begin to try to adjust for these to make sure that the groups, we have eliminated that variable as the cause for the outcome. So again, we're trying to make sure that both the intervention group and the comparison group are as balanced as possible. The other ways that we can do it would include sensitivity analyses that can be done through an active control measure or a tracer measure as well. So what we need to, again, just be aware of is that there are still unmeasured confounders that can play a very important role in being able to determine your outcome of interest. So this is an inherent limitation to our cohort studies, our observational studies, that we can try to minimize as much as possible, but there still will always be some sort of confounder that is at the end of the study. So I want you to take a moment and imagine that we have started conducting the study that we were talking about. You're enrolling patients into a prospective observational study of the Mediterranean diet versus diet for the outcomes of diabetes. And you collect the following information. You have 100 participants in each group, and we have the age, the education, the smoking status, and the amount of exercise of the participants per week. I want you to take a look at the graph, the table that's there, and tell me which of the following variables are most likely to introduce confounding. All right, we'll wait just a moment while the answers show up here. All right, so here in this case, we would be thinking about what is imbalance between the two groups, and are those associated with our primary outcome of interest of A1C? So here within our groups, so we have the answer of age. Well, the age difference between the two groups isn't too much. Do you expect that a difference of 2 years with a rather large standard deviation would really imbalance the groups to the extent that you would say, no, I cannot trust the results? In this case, probably not very much. This may indeed be a residual confounder, and we can adjust for that with statistical methods. And I think the same could be argued for high school education, although this may also be a predictor of their socioeconomic status. And as you may all are probably aware of, if you want better health, the more money that you have seems to be pretty consistent in terms of that within every disease state that you come across. So here, what I was trying to focus in a little bit more on was the imbalance in cigarette smoking. So those patients in the Mediterranean diet had 11%, which means that their A1C is probably going to be a little bit higher at the end compared to the DASH diet group. So now this is no longer due to the intervention, but due to these other factors. And the same goes for exercise. While there was more exercise in the DASH diet arm, so that means that their A1C is also probably going to be lower. So the Mediterranean diet A1C is going to be higher. So now you've got an imbalance between the two groups where it's going to be harder for the Mediterranean diet to show a difference just because of these risk of confounders that are there as well, or that are present within the study. I'll ask if anyone has any questions at this point in time before we carry forward.
Dr. Dan, I think there is a comment from Dr. Hadi in the chat.
All right, I cannot see the chat at the moment. Would you mind?
Yes, so Dr. Hadi said, I think in a similar study, we may need to match the groups for exercise as it is a documented preventative factor of diabetes.
Yeah, for sure. Totally agree. And thanks for your participation, Dr. Hadi. So this would be important information that, assuming that you can gather it and that you can gather it accurately as well. We'll talk about that in just a moment. But if you can gather this information at the beginning of the study, perfect. 100% fully agree you should match based on these. But perhaps you don't know the difference until the end of the study as well. And this is where the role of statistical adjustment comes in, where we now get new information and we can begin to adjust according to that. So there are a number of other threats to validity, and one of these is called information bias. This is a systematic error when participants do not remember previous events or experiences accurately, or perhaps omit details. So the question that you want to ask yourself here when you're reviewing cohort studies is, how is the data collected? How can we confirm that the patient was actually in the exposure arm or the control arm, or that they actually achieved the outcome of interest, or how that data was collected? As an example, if I were to ask you how tall you are, you would give me an answer. If I were to ask you how much you weigh, you would give me an answer as well. Now, the question would be is, all right, well, based on your report, how different is that compared to the truth? Well, you are most likely to overestimate how tall you are, and you are also likely to underestimate how much you weigh. So this leads us to the question of, how are we gathering that data? Is it objectively available, or is it subjective in some manner? If you were to report that to me, I would get a different result. If I were to ask your significant other, they would give me a different result. And if I were to objectively measure it, you would get another different result. So just to, again, think about what exposure or what outcome you're interested in and how you are specifically measuring that. And this sort of information is really important for retrospective studies, especially because we are interviewing the patients after the fact. Typically, the outcome or interest has already happened, and we're just asking them about previous exposures. And typically, just because we're human, we try to make and determine causality based on really little information and trying to find a cause of a specific bad fortune. So the solution is to try to avoid all of this in the first place, gather data prospectively, or at least have a way to objectively measure the information that is being gathered. One of the other major threats to validity that I wanted to cover today is about a mortal time bias. So this tries to answer the question of, was there a differential lag time between the start of follow-up and being truly part of the exposure group? And this is a specific form of what's known as misclassification bias that is unique to cohort studies. So this occurs again when there's a lag time between the beginning of follow-up and when the individual becomes eligible for one of the study groups. Typically, this is the exposure group. And during this lag time, patients within the exposure group or being classified as the exposure group can't die or experience the outcome of interest, perhaps, because this essentially gives them an apparent survival advantage. So let me show you this in a graphical format. So this would be the situation where we have the patients who were in the exposed arm, and let's say that our intervention was a prescription, and our unexposed group or our control group were those who did not receive a prescription. So the patient is discharged, the prescription is filled sometime later, and then they experience the outcome. Let's say it's admission for heart failure. The unexposed group, on the other hand, would be those who were discharged, followed up over time, and readmitted. This would be the truth. But what's happened here is that there's this lag time of when the patient was discharged and before they actually filled the prescription. So this is what's known as that immortal time, or the immortal time, where they have been misclassified. We're saying as part of the analysis that they're in the exposure group, but in reality, they're not. They're not taking the medication that we want them to be exposed to. And so our actual time that's classified is truly only this part here, and that leads specifically to bias, and can actually will lead to an increase, a complete nullification, or a complete reversal of conclusions. There are lots of examples in the literature if you want to search for immortal time bias in observational studies. To give you a quick example, there's one study that showed salbutamol, a beta agonist, reduces all-cause death in a cohort study of cardiac patients. Why? Because we have misclassified them, and that misclassification actually results in a completely weird outcome that doesn't make any sense at all. There's no reason why a smaller dose of salbutamol would improve cardiac outcomes. That doesn't make any sense. The same was found in the same study as for our gastrointestinal drugs, for example, proton pump inhibitors. Again, something that's not really, or doesn't make a whole lot of sense of why this is happening in the first place. So this is just proof to say that using a flawed statistical analysis can result in really important differences in the outcomes that you're looking at. So the solution to this is to have participants assigned to the exposure group on time zero, at the time at which they were actually exposed. And if this still does happen within our cohort study, we can do what's known as a time-dependent analysis to try to reduce that impact. It doesn't eliminate it completely, but it helps reduce it. So these, again, just key words for you to consider as you're reading through a cohort study to say, okay, they've done a time-dependent analysis. Is that a good thing or a bad thing? It's a good thing, and it tries to reduce that risk of immortal time bias.
Dr. Dan, there is one question.
Yeah.
From Ms. Miriam, the question is, when the numbers of patients are almost equal in both groups regarding the characteristics, does this lessen their confounders?
Sorry, could you repeat that one more time for me?
So when the numbers of patients are almost equal in both groups regarding their characteristics, does it lessen the confounders?
Yeah, so what we are hoping for is that the number that we make the groups as even as possible. So that we have ideally the same number of patients within the groups and that their characteristics are as similar as possible. But again, these only measure our known confounders. There still are perhaps a whole host of unknown confounders that aren't accounted for yet. And this is part of our residual confounding. And this is, again, part of the reason why cohort studies are not considered to be the gold standard, is because there could be residual confounders that we just didn't even measure because either we don't have the resources to measure or it wasn't even measurable in the first place. So let's carry on to a question here. So participants were, as part of this study, were instructed to keep a strict record of daily food intake for the 3 months that we are studying our patients. The Mediterranean and the DASH diet scores were calculated according to previous reported studies. According to this information that's provided to you, do you believe that there is what is the risk of information bias for classification into the exposure group or the control group? How would you rate this? As a serious risk, high risk, a moderate risk, or a low risk? All right, so I understand that it's perhaps not a whole lot of information to go off of, but sometimes this is the case of that's all that's reported to us as part of a cohort study. So in this case, many of you have classified this as serious or high risk. And well, depending on what sort of information you would be looking for, this could be valid. Based on what's been described here is, well, we're trying to measure the difference between Mediterranean diet and DASH diet. Participants keep a strict food record of daily food intake over every day for the next 3 months. So it's not recall bias that's here, because if you tried to ask me what I had for dinner 3 days ago, I couldn't tell you the answer to that. Even the proportion sizes of the food that I was eating, couldn't tell you that. But since this is prospective in nature, they're taking a strict record, and that there are potentially some similarities between the Mediterranean diet and the DASH diet, we could just take a look at all of the sort of foods that were eaten, take that information, throw it into a calculator and say, how close were you to taking the Mediterranean diet? Or how close were you to taking the DASH diet? And get a score based on that and use that as part of our analysis. So I would be more inclined to classify this as either a low risk or a moderate risk, depending on what additional information that you were looking for. So one thing that I will say is that if you are rating this as serious or high risk of bias in any situation, I think always need to ask yourself is, what would you want to see instead? What is better than what the researchers have done based on the study and research question that is presented to you? If you can't answer to that, you might be being perhaps a little bit too harsh when you're coming to your critical appraisal. So let's carry on with some other threats to validity. This is outcome misclassification. So if you are doing more of a database study, this can occur in random, or it can be biased in nature. Random would be just simply putting in the wrong ICD code as part of the database. Therefore, the disease that the patient has been classified as has been misclassified. That's sort of a bottom line. This reduces a study's power and the ability for us to find a difference. There is a biased misclassification where the subjects in one group are more likely to be misclassified than another. And this either leads to an exaggeration of effect or an attenuation of effect. And again, that very much depends on the study that you are looking at and the outcomes of interest. The solutions to this are really to have really clear objective diagnostic criteria and to make sure that it's reliable between assessors. We also want to make sure that there are checks and balances within a study to ensure that there was appropriate valid data that was gathered with minimal errors. So as we mentioned before, as part of the weight example, how are you collecting the data? Is it self-report? Is it in the morning? Is it in the evening? All of these have potential variations on the outcome of interest. What would be similar, and I think everyone is probably aware of this, the attrition bias. This is where we have a loss to follow-up that happens. And we don't know what happened to a number of the participants in the study. So here we need to ask ourselves, is there a systematic reason for participant withdrawal, loss to follow-up, or perhaps incomplete data? Another specific cause of threat to validity within cohort studies is what's known as reverse causation or protopathic bias. These both mean the same thing. This occurs when a precursor to the outcome of interest or a subclinical version of it leads to the outcome or exposure of interest. The full-blown version of this outcome of interest presents itself after the outcome, which then leads us to the false belief that the exposure caused the outcome, instead of it being the other way around. The outcome caused the exposure. As an example for this, a patient taking analgesics due to pain because of an unknown tumor that within a cohort study led to the conclusion that analgesics caused the tumor. Well, that's not correct. The outcome caused the exposure. The pain from the tumor caused the taking of analgesics. Taking it into the perspective of our question, a patient changes their diet in response to being labeled a pre-diabetic, leading to the conclusion that the Mediterranean diet causes diabetes. So we can see that there's this reverse causation that happens, and this we need to ask ourselves when we're looking at the outcome and it just doesn't seem to make sense. Ask yourself if there's reverse causation or protopathic bias that exists. So as our study continued, so we had 100 patients in the beginning of each arm at the beginning of the study, and as our 3 months rolled around, well, we lost 27 patients to follow up in the Mediterranean diet and included 73 patients in the analysis. And within the DASH diet, we only lost 1 patient, and we included 99 patients in the analysis. We come to the conclusion, based on all of our statistics, that the Mediterranean diet significantly reduces A1C and BMI compared to the DASH diet. What would you assess the risk of attrition bias to be within this study? Do you think that the loss to follow-up perhaps could have impacted the results? So would you label this as serious, high, moderate, or low risk? So the question that we're asking here essentially is, what do we think could have happened to these patients who were lost to follow-up? Could these patients had a higher A1C and they dropped out and therefore showing that Mediterranean diet significantly reduces A1C? Or perhaps these were patients who simply couldn't follow the instructions or weren't able to be classified as part of the Mediterranean diet. And many of you answered correctly that we would probably label this more as a high risk of bias, or perhaps in some cases you may even call this a serious risk of bias. And that generally speaking, if there's more than about 20% loss to follow-up that's happened, then we really need to consider the effects of attrition bias within that study. We can also look at it from the perspective of event rates, but we won't go into the details of that today. You'll discuss that as you talk about RCTs and the critical appraisal of it in future sessions. So just to wrap up some of the few other things that we would want to be looking for within cohort studies is the strength of the association of the result. If you have a large association, so your odds ratio or relative risk is more than 5 to 10, this generally means that it does have a true association between the outcome and exposure. We may perhaps want to look at other studies to see if there's a dose-response gradient. Again, this would lend us more validity to the cause and effect if we meet all of those Bradford Hill criteria. How precise is the confidence interval? If it's very wide, well, that's an imprecise result, and we would not trust it as much as one that is quite narrow, showing a more perhaps reliable result. So when we're thinking about the external validity, just a few things to consider. Does my practice setting differ significantly from that in the trials? Did they use the same diagnostic criteria that I would use? And this really comes to if it being the studies being done in the same era. So studies being done 50 years ago or 30 years ago could have different diagnostic criteria for specific diseases, and we do need to pay attention to that. What is the setting? Is it a single versus multi-centered study? Or is there a reasonable genetic risk factor that would say that I can't apply that to here? Are there differences between patients, or differences between study participants and the patients that I see? Here we can think about the patient, comorbidities, race, age, previous medications, and pathology, or the SCRAP mnemonic, for us to be able to think about how generalizable these results are and if it is applicable as well. Think about if your intervention can be done in your context and if you can measure the outcomes as accurately as what is in the study. So how do I put all this together, all of this critical appraisal information? Well, critical appraisal is subjective. You came and you probably saw that, well, some people have different judgments compared to me. And it's really important for us to recognize the weaknesses that may limit the validity and reliability of the study to judge how useful it is going to be in our practice. When we're looking at cohort studies, we always have to ask the question of, is there better quality evidence that's available? Because according to what's known as the grade criteria, observational studies start at a low grade of evidence. And there are certain factors that can increase that to a moderate and perhaps even to high precision and reliability and validity of the evidence, but more than likely it's going to go down due to some of those risk factors that we talk about or threats to the validity within these studies. If there's anything that you take away from my part of the session of the critical appraisal is to screenshot this screen. These are your tools for a systematic approach to assessing cohort studies. Now, we'll go over some new things that we didn't have the chance to talk about today, but each of these different tools do come with an explanation document as well, so that you can go read through it and understand what you are appraising, so that you can come to an accurate and probable judgment of the cohort study that you are looking at. So these are just a couple of references that are here for you, and I'll open up the floor to any questions at this point, and if not, then I will pass the ball back over to Dr. Kazim. And if you're still awake, say hi in the chat to us.
Okay. Thank you so much, Dan.
All right, the ball is yours, Dr. Kazim.
Okay. Okay, thank you so much. Good evening, distinguished ladies and gentlemen. My name is Kazim Yusuf. I'm from the College of Pharmacy, Department of Clinical Pharmacy and Practice. And we'll be going through in a very systematic manner how to design, conduct, and interpret quantitative surveys. Okay. Now, Dr. Azem briefly spoke about the different study designs that are available for conducting a study. One of the commonly used study designs in cross-sectional survey is the cross-sectional studies. Now, we know that all the different study designs that are available, they have their strengths and weaknesses. That's number one. Number two is that it's important for us to know that the most important questions for us to ask before we start our study is, what is our research question? Because essentially the research question is what would determine the appropriate research method or study design that we need to use. Each study designs have a strength and weakness, like I said. Therefore, no one study design is actually better than the other. The question we should ask is the study design that I have selected, is it appropriate for the research question or the objectives of my studies? And this is where it's important for us to know that for cross-sectional survey or for quantitative survey, the cross-sectional design is actually the most appropriate. I will also emphasize the fact that, like Dr. Azem said, a cross-sectional study gives us a snapshot of our object of interest. So it's a study that is conducted to give us an idea of our object of interest at a point in time. And I did recall that he mentioned that these are often used in prevalence studies. Okay, so this is also very important for cross-sectional surveys. Now, what is a survey? A survey simply is a method which is used for gathering information about specific characteristics in a specific target population. And often they are used to provide a window, an excellent insight into wide spectrum of human experience or human behavior, which include things like perception, attitude, opinion, practice, or knowledge. And you will all agree with me that there are limited number of study design that you can actually use to answer questions related to human behavior. Randomized control trial, systematic review and meta-analysis, as robust as they are in terms of the level of evidence they provide, are not really appropriate for providing an excellent insight or window into human behavior or human experience. The appropriate research design to use is a cross-sectional survey. Okay, so that's one. Number two is that a cross-sectional survey or a quantitative survey is also excellent for conducting a need assessment, whether it's a training need assessment or an assessment which is focused, on providing answers, towards identifying appropriate intervention, to improve, a defined objective. We can also use a quantitative survey or a cross-sectional survey to assess the impact of an intervention. Okay, for example, we want to find out at the end of this session, this training session, what progress have we made regarding our knowledge of how to design, conduct, and appraise a cohort study, or how to design, conduct, and interpret a cross-sectional survey or a quantitative survey. Therefore, a survey is an important tool that we can use to answer specific research questions. And I'm going to throw more light on that as we proceed. Now, what are the key characteristics of a quantitative survey? The first one is that it is a systematic research method. Because often when we hear the word survey, it connotes something that means, okay, we just design some set of questions and we go and interview people. Yes, it involves designing questions, and it also involves interviewing people or interacting with human beings to provide answers or responses that will be useful for answering our research questions. However, there are systematic methods or steps that are essential for us to follow to ensure that we actually conduct a survey that will provide us findings that are valid, reliable, and can provide us a valuable insight into whatever focus our study is whatever is the focus of our study. That's number one. Number two, it must be reproducible. Reproducibility in terms of ensuring that we take adequate precaution in the design of the data collection tool and the sampling method and the statistical method that we decide to use to analyze our study, such that we'll be able to get similar result or almost same result if another person or another set of researchers decides to use the tool that we adopted in the previous studies. A third characteristic is that quantitative surveys are specifically very, very useful for describing specific characteristics. Okay, for example, we may want to find out in a sample of diabetic patient or patient living with diabetes, what is their attitude towards adherence to lifestyle and dietary modification. Okay, or we want to find out from this same group of patients, what is their illness experience, or what are the challenges that they are encountering with taking their medications. The appropriate method to use is actually a quantitative survey, and we're able to provide us a window into the patient experiences regarding all these various focus. Number two, we can also use a quantitative survey to examine or explain relationship or trends. For example, this same group of patients, we want to find out, for example, how many, let's imagine that you have this group of patients and you are interested in assessing adherence to medication. For example, we may want to find out how many patients who are adherent, how many patients who are non-adherent with their medication. Of the patients that were adherent, how many of them are males, how many are females? Okay, of those who are females, how many are adherent, how many are not adherent? And we can begin to identify trends or patterns. For example, we find out that females appear more adherent with their medication, and this can, generate hypotheses which we might want to go further to investigate. The third focus is we can use a quantitative survey to actually predict relationship between different characteristics or different components of a phenomenon. In which case, for example, we may want to, for example, using appropriate statistical method, actually determine whether gender predict adherence to medication among diabetic patients, in which case we'll be making inferences or judgment. And this can, provide findings that can be used to design interventions to improve adherence to medication among patients who are diabetic and not using their medication for one reason or the other. The fourth characteristic is that for quantitative survey is that sampling from a target population is crucial. Okay, remember we're dealing with people and human beings are complex. We're studying construct that has to do with behaviors. And like it was mentioned by the previous speakers, you could have people having problem recalling certain information. So you could have recall bias, or you could have challenges with people not giving valid response because of certain factors related to the data collection tool. For example, maybe they don't understand the question, or maybe the question, the questionnaire items are worded in a way that makes it difficult for them to actually follow through in understanding and actually providing valid response that actually represent their experience. So we'll talk more about this when we get to the steps that we follow in designing and conducting a robust quantitative survey. The last one is the appropriate tool for collecting data in a quantitative survey is a questionnaire. And the questionnaire is not just simply a piece of paper containing a list of questions. There are systematic steps that we need to follow, or that we must follow, to ensure that our questionnaire is not only valid, it's also robust and is reliable, such that it can provide us responses from our target population that we're able to answer the research questions that we pose in our study. Now, what are the steps that we need to follow, or that we must follow, to design, conduct, and interpret a robust quantitative survey? There are 8 key steps. The first one is to define our research question in a way that is clear and that is unambiguous. This is crucial because it, like I mentioned earlier on, our research question is what would determine our study design or research method. It's possible that if we did not do this, we might not be able to identify the validity of using a quantitative survey for our study. So it's important for us to define from the outset our research question in a very clear and unambiguous manner. And we can use two major strategies to do that. The first one is the final strategy. Number one, is it feasible? Is our the research question or study objective is it doable? And this can be divided into about three major components. For example, how politically feasible is our research question? Is it possible that these questions can rob the political leadership in the wrong manner? For example, let me give an example. You want to conduct a study in Qatar University, for example, and the leadership of the university are concerned that the findings you're likely to get from your study will put the university in a very bad light. Okay? Such a study, you're unlikely to get the necessary approval that will ensure that you are able to conduct your study in a very seamless manner. For example, you may not get access to the staff in the university or to the student. Okay, and if you don't take that into consideration from the beginning, your study might run into a problem. That's number one. Number two is technical feasibility. Can you get people with sufficient expertise that are relevant to your study, either as research assistant or data collectors? Or is it possible that you probably have to bring in external collaborators with required technical capability? Again, it's important to give give a thought to this at the beginning of your study so that, again, you don't run into trouble by the time you start. And the last one is financial feasibility. How feasible do you have the resources because you are going to be printing your questionnaire or you're going to be, depending on your sample size, you might require a number of research assistants. So do you have enough resources? So it's important for us to, which is one of the reasons why it's important for you to define your research questions clearly at the beginning. Number two, interesting. Is your research question really interesting? And this is important not only for the researcher, also for the studies participant, because you want a situation where the questionnaire will generate enthusiasm such that they can open up and provide an excellent window into their experience, and therefore respond in a way that is usable and that will ensure that you have sufficient data of good quality to analyze and see whether you can use it to answer your research question. So this is very important. Number three, novelty. Now, it is important to ensure that your research question is novel enough. Novelty in terms of originality of the findings. Because I imagine that after you finish your study, you want to disseminate your findings. You want to publish your findings, or you want to present your findings to maybe stakeholders, government officials, or people in management, so that your findings will be have potential impact, maybe change practice. Okay? Or you want to publish your finding in scientific journals, and you want it to be read by people all over the world. So novelty enhances the ability for you to disseminate your findings in credible scientific platform. Number four, ethical. Okay, this is important also to ensure that your research question will not violate, ethical principles. You're going to be dealing with people, and people have rights, and you want to ensure that your research will not violate or invade people's right. And this is also important for ethical approval. Often before you start your study, you need to ensure that you present your protocol to an institutional review board, and the ethical component of your study will be an important point of appraisal, while during the approval process. The last one is relevance. Okay, it's important for us to ensure that your research question is relevant. It will answer provide findings that will change practice, improve the way things are done, and also we make meaningful contribution to knowledge. Now, the second part is it's important for you to determine whether the focus of your research question is descriptive, explanatory, or predictive. Now, why is this important? It is important because before you start your study, you should begin to give a serious thought to what kind of statistical method will be appropriate for your study so that you can make adequate plan right from the outset. Now, number two, the second step is to assess the need for a preliminary survey. And one of the methods that is used here is called a focus group discussion. Now, why is this important? It is important particularly for situations where there are no available questionnaires. Like we said earlier on, a questionnaire is the tool that is used for data collection in quantitative survey. So if you don't have an existing questionnaire which you can adapt or which you can adopt, it means that you have to create your questionnaire from the scratch. And for such a situation, it's important to always start with a preliminary survey using a focus group discussion of about 6 to 10 persons. So usually you select these from the target population that are appropriate for your study. And it's actually an in-depth discussion that will provide you an insight or ideas that you can now use to generate hypotheses that will be relevant for your study, and also give you idea of what kind of areas to focus on when you are designing your questionnaire. Okay, that's number one. Number two, it will also give you an idea of what kind of items, questionnaire items, that you will need to include in your questionnaire. So a preliminary survey is particularly important for when you don't have data collection to a question that is already designed and used by previous researcher or published, and you can adapt. Adaptation means that, for example, you take that and you adapt it to local, peculiarities or local factors, or you can adopt wholesale if you don't have a lot of differences between the factors that are obtainable in your locality and where the questionnaire originated from.
Dr. Kazim,
yeah.
Dr. Kazim, one question regarding the focus group discussion. So okay. the members of the focus group, should they be members of the sample population?
Excellent, thank you. Yeah, it's important to ensure that the people, and I think I mentioned at during my discussion of that aspect, that the people you are going to include in your focus group should, as much as possible, be similar or be similar to the target population that you want to use for your main study. Because you want to, for example, like I said, you don't have a questionnaire that is available, and you want to design a questionnaire and you ensure that you cover all the relevant aspects depending on what your research question is. And this is one of the reasons why you have a small discussion with a focus group where you can have an in-depth insight into their experience that are relevant to whatever research question you are posing. So it's important to ensure that the people that you include in your focus group are similar to the target population you are going to use for your actual study. Okay, thank you so much. Now, the third step is a clear definition of your target population. Okay, now again, this is very important for a number of reasons. Number one, it will enable you, like I mentioned, to enable assessment of feasibility of a survey. I'll give you an example. Let's imagine that you want to conduct a study here in Qatar, and it has to do with quality of life of patients with HIV/AIDS, quality of life among patients, living with HIV/AIDS, whether you want to look at physical functioning, social functioning, or occupational functioning. Now, you're unlikely to get a lot of people here in Qatar with HIV/AIDS. If you're lucky to get at all, it will probably be a very small group. So you want to give a thought to that to think, do you want to go ahead or not? Okay, that's number one. Number two, if you decide to go ahead, you know that you might have some challenges with having access. These are likely to be hard to reach population because there are not very many. There are probably cultural issues or stigma associated with sexually transmitted diseases in this locality. So getting access to them might be challenging. So you want to give a thought to that, which is why I said this will also be useful. Defining your target population will also be useful for you in determining the sampling method. So let's imagine that you're still interested in conducting a survey, this survey, quality of life survey, among patients living with HIV/AIDS, and you know you're unlikely to get many of them. Okay, now there are some sampling method which is appropriate for this. Okay, an example is, for example, you can use a purposive sampling. That's number one. Or you can use what is called a snowball sampling method, in which case, for example, you are lucky to identify a patient with HIV/AIDS, and from that patient, you can get referral to other patients because you don't have a lot of people with such disease condition in Qatar. Okay, that's number two. Number three is defining your target population is critical for a valid result because it's from your target population that you're going to select your sample. So if you don't have an idea that whether you're able to get people with the characteristic that is important or that is consistent with your research question, then there's no point, continue with the study. So it's important for you to define this at the beginning before you set out to conduct your study. Number four, sample size calculation. Dr. Azin spoke briefly about this. This is very critical, particularly for quantitative survey. Remember, we said there are a lot of interferences by bias that can come in. So it's important for us to ensure that we calculate the minimum required sample size that will ensure that we're able to generalize or transfer our findings from our sample to the target population. Because it's actually impossible to include the whole target population, which is one of the reasons why we must sample using an appropriate method. So if you calculate the sufficient number of people that you're going to need for your study, that ensures that your study have sufficient power to detect a difference, indeed, if there's one. Okay, that's number one. Number two, what are the components that you need to calculate your sample size? I'll just mention them briefly. And by the way, there are varieties of online calculators that are available on the internet, and you can use them to actually calculate your sample size. The first thing you need is the target population size. So if, for example, in the example I gave you, are interested in a patient living with diabetes in Qatar, you've got to have an idea of what is the population of patients with type 2 diabetes in Qatar. That's number one. Number two, what is the confidence interval desired? Usually it's put at 95%. And like I think Dr. Azem and Dr. Dan also mentioned briefly about it, the confidence interval is very critical to the precision of your estimate. So you don't want to have a very wide confidence interval. Often the confidence interval is related to your sample size. The higher the sample size, the narrower the confidence interval, and the more precise is your estimate of interest. And on the other hand, the smaller the sample size, the wider the confidence interval, and the less reliable the precision of your estimate. And the third one is your alpha level, which is your probability of chance interfering with your interpretation of your result. And the last one, of course, is the expected level of response. Now, this is important here. Often people tend to be conservative here. There are no cutoff or there are no convention regarding what percentage in terms of expected level of response. But usually, what you find in literature is about 50%. You want to be as conservative as possible, and so that you don't overestimate, and you get to the field and you find out that you don't have enough response, which can undermine the validity and robustness of your result. Often you have to add an additional percentage to account for non-response, because like I said, ethics is important. You need to obtain consent before you interview people, and some of them might decline participation. So if you don't add a certain percentage, sure that you account for this, this can affect your study power I'll give an example. Let's imagine that your calculated sample size is 300. So therefore, you want to add like 10% to that. So so that your target sample size will be 330. That will account for example, some of your study subject declining participation, and that will not affect the minimum required sample size that you need to produce a valid findings for your study. Number 5, the sampling method and procedure. Now, this is critical to external validity. I'm not going to belabor this. Like Dr. Dan mentioned, external validity has to do with the generalizability of your result. How generalizable is your result from your sample to the target population? Okay, and so it's important to ensure that you select appropriate sampling method that will ensure that your sample actually is representative of your target population. There must be no variation. As much as possible, you want to minimize variation so that whatever findings you got from your study using a sample, you can transfer that to the target population. So sampling method is critical for external validity. That's number 1. Number 2, it's also crucial for internal validity. Okay, it's also crucial for internal validity. Now we have 2 major types of sampling method. We have the probability sampling method, which gives every member of the target population equal chance of being selected. Okay, so there's no bias in selection. You want to avoid selection bias. So everybody has equal chance of being selected. There are some sampling methods that that fit that bill. Then you also have the non-probability sampling method, okay, which are prone to selection bias. Okay, again, this is one of the reasons why it's important for you to define your research questions and your target population from the beginning, so that you can decide which of these 2 types of sampling method will be appropriate for your study. The last one is your research question. This is also an important determinant. Your research questions will also determine whether you should use probability or non-probability sampling method. But generally, probability sampling method is preferred, okay, because you want to ensure that every member of the population has equal chance of being selected, so that you can enhance the validity and robustness of the result of your survey. Number 6 is the development of data collection tool, which is your questionnaire. Now, it is crucial for you to define the goal of your questionnaire. There must be no daylight between the goal of the questionnaire and the research question. Because after all, the questionnaire is the tool that you want to use to collect data that you want to use to answer whatever question you're posed in your research. Therefore, it's important to define the goal right from the beginning. And you can determine whether you want to adopt, if it is available, or you want to adapt an existing questionnaire or develop a new one. Okay, if you have to develop a new one, like I mentioned earlier on, you will need to conduct a preliminary survey using a focus group discussion to do that. Now, there are 2 types of questionnaires, okay, and these are based on the structure. Often you find in quantitative survey, we use structured questionnaire. These are often self-administered. You can leave them behind if you want to. You use face-to-face method as a data collection method, or you can use online platform like SurveyMonkey, or several other available online applications that are available, especially in this COVID-19 era, to conduct your study. You also have semi-structured questionnaire. I'm not going to spend too much time on this. This is often used when you are using a mixed method design, where you have quantitative survey combined with some form of qualitative interviews. Often here you have a structured questionnaire, and you also have a list of questions which will be administered or asked during the interview by the data collector. So usually for a semi-structured questionnaire, you will need a recording device, whether it's digital device, or you have a notepad where you can you can write down or jot the participant response. And for this, usually you do qualitative data analysis, which is thematic analysis, and you can use either inductive or deductive method for analyzing your result. Now, what are the advantages? Straightforward. For structured questionnaire, it's easy to use. Resources are minimal in terms of staff, personnel, time, and cost. It is often the best tweeted method for if the responses you are looking for are confidential, because usually you leave them behind, and the study subject can have their privacy to be able to sit down and answer without being embarrassed, in any way. Okay, that's number one. Number two, it's also offer the greatest flexibility. Okay, you can, like I mentioned, you can leave them behind, or it can be done online, and this respondent can answer, at their pace, and provide a meaningful response, rather than something that is invalid or not robust for your study. The disadvantage is that there's a high risk, of course, non-response bias. Okay, this could be intentional for a lot of reasons, which we're going to be discussing, or it could be unintentional because of the fault in the design of the questionnaire. Now, what are the key considerations in wording your questionnaire? What are the things you must take into consideration? Number one, the clarity of the question. This is very important. Remember, you're not going to be there. It is self-administered. You're not going to be there when the respondents are providing their response. So you won't have the luxury of being there to clarify. So clarity is very important, which is why it's important for you, before you go out, you must pre-test your questionnaire, or do what is called a pilot testing. And a pilot testing involves, again, taking a very small sample of 10 or 20 members of the same target population you want to use, and you administer the questionnaire, on this, limited number of subject. And you're looking at, for example, ambiguity, difficulty with understanding, clarity, comprehensiveness, so that you can address all these issues before you provide the final draft of your questionnaire and go out to collect your data. The second thing you must consider is avoid questionnaire items that annoy, intimidate, embarrass, or offend the subject. Okay, now this is important because you want to, as much as possible, maximize response. There are two things you need to be cognizant of. One is called the response rate. The other is completion rate. Response rate and completion rate. Response rate, you want to, as much as possible, maximize the number of subjects that respond to your questionnaire. And not only that, you also want to ensure that you have, as much as possible, a usable number of completed questionnaires, so that you can run a robust analysis of your data. Okay, so you may find situations where questionnaire are half-filled, for example. Maybe they leave half of the item, and it becomes difficult to make any sense of, or draw any meaningful inference, because a lot of data are missing because they left out so many questions. So as much as possible, avoid such. You also want to avoid academic terminologies, jargons, words or phrases that they are not familiar with, which is again one of the reasons why you must define your target population. Know your subject, so that you can tailor the wordings, the kind of adjectives, the words that you use to fit the peculiarities of the target population. And the last one is to ensure that you follow the principle of KISS. KISS, which is keep it short and simple. Okay, but don't sacrifice comprehensiveness for brevity. Ensure that the questionnaire is short, straight to the point, and will not belabor cognitively your study subject. Avoid double negatives. Things they make it difficult for them to understand the items. And if a subject felt that they have to stress their brain to answer a question, often what they do is just abandon the questionnaire, and you may have either a poor response rate or poor completion rate. Avoid hypothetical questions. You want to ask questions that are real, that mirrors their life experiences, so that they can actually provide you a valid response. I've talked about sensitive questions. As much as possible, you should categorize them. Okay, and when you do that, you're able to desensitize, and your study subject can hide, to use that word, under the anonymity and be able to provide correct answer to your questions. Type of questions, it could be open-ended or closed-ended. Open-ended provide opportunities for your respondent to give you more information so that you can understand the why on the underlying whatever information they have provided to you. And this is an example of scaling that is used for closed question. It could be dichotomous, yes or no, or you could have multiple response options, or you can also use a scale. Okay, Likert scale is a very popular scale that is used in quantitative survey, ranging from 1 to 6, and you see these are opposing adjectives: strongly agree and strongly disagree, and you ask them to rate their response. Or you can use a visual analogy scale, which could be broken lines or unbroken lines, and the respondent can indicate, depending on what they feel about the questions, to your questionnaire. Now, your layout is very important. It's important to ensure that the questionnaire is is attractive and organized. It's easy on the eyes, so that can also increase the enthusiasm of your study sample to be able to provide answer. Length is very important. You don't want a too long a questionnaire, such that this might discourage the study subject from providing response to all the questionnaire items, or even completely abandoning responding to your questionnaire. You want to ensure that you prevent that. Clear instruction at the beginning, introducing yourself, your organization, the purpose of your study, and you assure them of the confidentiality in how you are going to handle the data. The last thing to do here is to ensure that the questionnaire items follow a logical sequence. Okay, this helps the respondent to understand and follow the trend in the questionnaire, and that makes it easy for them to be able to answer the questions. Now, again, it's important, I think I've mentioned this, it's important to ensure that you avoid very difficult questions, particularly at the beginning, because this might discourage the study participant. Group items that are related into different sections. Okay, this is also important for assessing the psychometric strength of your questionnaire. Now, the seventh step is to assess the validity and reliability of your questionnaire. And I'm not going to spend too much time here. Validity has to do with ensuring that your questionnaire actually provided responses that they intend to measure. This is critical to the internal validity of your result. And how do you do this? Validation is in two ways. Number one, you have what is called face validity, which is actually a part of content validity. And content validity is done by showing your questionnaire to experts in the research area. Because these are people who are experienced in the research area, and they can look at your questionnaire and ensure that you have actually covered all the key constructs that are related to your research question. The second one is reliability analysis. Reliability analysis has to do with ensuring that your questionnaire produces results that are reproducible if it is used by other researchers. And usually it ranges from 0 to 1, with 0.7 considered acceptable. The last thing is pretesting, which I think we have talked about previously. Data collection and statistical analysis, this is very important. Your data collection procedures must be standardized, especially if you are using more than one research assistant, because as much as possible, you don't want a situation where this interferes with the validity of the findings. And of course, the statistical analysis, I mentioned that this is part of what you must do from the beginning, depending on the focus of your research question. Is it descriptive? Is it explanatory? Or is it predictive? This will determine whether you are going to be using mainly descriptive statistics, or you have to use inferential analysis, which involve hypothesis testing. And the last thing here is to watch out for the different type of bias that can interfere with your result. The first one is social desirability bias. Okay, now people are expected to behave in certain way. Okay, so if they're not behaving in that way when they are asked, of course they will respond in a way that is socially desirable. This is very common with quantitative survey, which is one of the reasons why you must ensure that you design your questionnaire item in a way that will minimize this. Recall bias, this is also very important. Okay, so you're doing a survey, you want to have an insight or a window into people's life experiences. Okay, so the way and manner you word your questions can have a lot of impact on the level of recall bias that you will encounter in your survey. Response bias or non-response bias, all these are tied. Volunteer bias, all these are tied, to the way and manner you design your questionnaire. While selection bias often has to do with your sampling method. Okay, you want to, as much as possible, like I mentioned earlier on, ensure that your study sample is representative of your target population. Thank you so much. Now we'll have a couple of questions that we can use to just see how far we have gone with learning about how to conduct, design, and interpret continuous survey. The first question is, AX set out to conduct a study focused on describing the pattern of antihypertensive medicine prescribed for hypertensive patient at a medical outpatient clinic in Qatar. Which of the following research method is the appropriate, which of the following research method is the most appropriate for AX study? 1, quantitative survey of a sample of hypertensive patient. Number 2, a preliminary focus group discussion with selected hypertensive patient. Number 3, a cross-sectional review of all medical records of a sample of hypertensive patient. Or number 4, a quantitative survey of a sample of physician attending to hypertensive patient. Dr. Zakaria? Yeah, I can't.
Yeah.
Yeah, I cannot see
We
the
still,
polling. Okay.
yeah, we still have people registering their answers. You have another 5 seconds.
Okay.
Okay, so the poll is closing now. You can reveal the answer, Dr. Kazim, and begin your discussion on the answers.
Okay. I cannot see the result of the polling.
It takes 20 seconds to load the result.
Oh, okay. All right. Okay. If you look at this question, okay, yes, I have it now. Yeah. Okay. We have 10 people. Yes. Okay. The majority selected actually the correct answer. The correct answer here is cross-sectional review of medical records of a sample of hypertensive patients. Because if you look at the research question, it says a study focused on describing the pattern of antihypertensive medicine prescribed. Now, this can be done with a survey, but the validity of the result is questionable. I mean, you're asking the patient what kind of antihypertensive patient was prescribed for you. Okay, you may have interference with recall bias here, for example, in terms of some patient may not remember, or because they may not want to admit that they don't remember the medicine they are taking, and they give you the wrong answer. So the correct method to use is actually a cross-sectional review of medical records. And this is one of the reasons why it's important to define your research questions right from the outset so that you can select the appropriate research method to use in providing answer. The second question, XY plan to conduct a quantitative survey to measure the attitude of physicians and nurses towards patients with confirmed COVID-19 infection. Which of the following appropriately capture the objective of XY study? Okay, very good. Okay. Again, okay, we have here A, which is one, we have exploratory, descriptive. Okay, so we have 9 response regarding that and 1 for, okay, if we look at the research question, you see it says conduct a quantitative survey to measure attitude of physician and nurses. Okay, so what we're doing is actually describing a characteristic. What is the attitude of physicians and nurses towards patients with COVID-19? So this is a study focused on just describing an attribute. Okay, so we had 90. Now, it could also be exploratory. Now, for exploratory survey, you will not be using a quantitative survey for that. Exploratory often involve qualitative methods, like, for example, a focus group discussion, or you can have a mixed method where you have use of semi-structured questionnaire. Okay. The third question is AB conducted a quantitative survey, which is structured happiness and personality questionnaire to examine the hypothesis that people with personality of an extrovert are happier. Which of the following appropriately capture the objective of AB studies?
Okay, Dr. Kazim, the poll is just closing now. I think we should probably make this the last question.
Okay.
So while the polling is just closing, I just want to thank everybody for attending. And of course, I want to thank our excellent panel today, Dr. Kazim, Dr. Daniel, Dr. Hazim, and also Mr. Shuja and Ms. Sahat, and for their help in setting up this event. I've definitely learned a lot from today, and I hope everybody else has benefited equally. We have a couple of events next week, so please check out the website and look forward to welcoming you to next week's event. Now back to Dr. Kazim to give you some feedback on this question.
Okay, all right. Okay, so we have exploratory 8, descriptive 4, explanatory 4. Okay, predictive we had 2. Okay, now if we look at the question, it says a quantitative survey which is structured happiness and personality questionnaire to examine the hypothesis that people with personality of an extrovert are happier. Actually, this question is sorry, the focus of the question of the research question is predictive. It is predictive. You have an hypothesis that people who are extrovert are happier. So you collect your data and you can actually use the appropriate statistical method to determine whether there is a relationship or whether actually extrovert personality predict happiness. Okay, so predictive is actually the correct answer. Thank you. We've come to the end of my section of the event. Thank you, Dr. Zach.
Thank you once again to our panel, and thank you to all the participants today. Like I said, I hope you've benefited from today's event. We'll have part 2 of our quantitative series next week on Tuesday. But before that, on Monday, we will have an event to raise awareness around World Mental Health Day. So we have Dr. Suhad and Ms. Taysir presenting on psychosocial models and social cultural determinants and coping strategies during COVID-19. We've made the WebEx links available for you on the website, so this should make it easier to log in. However, if you would like to register for CPD points, please use the registration link and complete the registration form. And once again, thank you to everybody for attending, and thank you to our speakers today. Thank you. Good night, everybody.
Okay, good night. Thank you, Dr. Zach. Bye.
Thank you, everybody.